Good afternoon. Uh, I thank Dr. Republica and her team for involving me in this very important conference. I just saw the theme is geriatrics, oncology and palliative care. I think that's exactly what most of us will be doing when we take care of our older adults or elderly. So older age itself is a challenge, as many geriatricians would agree with me, and older adults with cancer, which is one of the major comorbidities of aging, then it becomes all the more challenging to deal them as a special population. And we'll see how to improve quality of care in this individual with a comprehensive approach. So why we know that? Because in India also the aging process is more, and we are longevity is much more, and we will have more and more elder adults being treated in the future. At Tata Memorial Hospital, in the medical oncology department, more than 33% of all the patients coming in have become more than 60 years, and it's going to increase. So we know that aging population is what we may have to deal with when we look at diseases like cancer, and this is the society which is doing a lot of work in the geriatric oncology stakes in India. So when we look at who are the key stakeholders to improve the quality in a geriatric oncology clinical services, of course geriatrician or the elder care physician becomes the fulcrum of the patient care, and then of course we have the oncology team, and I think the most important person would be a palliative care physician, because when we look at oncology in general, what we talk about, the golden endpoint is overall survival. That means we all want our patients to live longer. But in geriatric oncology, it's very unique that many of the time we don't have a hard set endpoint where we give treatment based on we need to improve the survival. It just, if you can prevent falls, if you can reduce the hospital visits, you can change from injections to oral tablets, you improve the quality of life, you improve the time at home. All these are endpoints which we need to achieve in geriatric oncology, and that can be achieved by a comprehensive team of medical professionals, which will include palliative care physicians, oncologists, and geriatricians. So many times what we forget when we are in a tumor board or when we are in a scientific forum is what is the patient preference, especially in a disease like cancer, where our endpoint is overall survival, means we have to aggressively treat them. But that's not the case. We had a survey done under the Geriatric Oncology Society and asked very simple question. If you are a senior citizen and you are diagnosed with cancer, what is the thing that you want? So if you can see that multiple choices were given, and it's very unique to see that best chance of cure, of course, was there in 46%, but many wanted improved quality of care and least number of visits to the hospital. Now the most important problem is the caregiver and the patient. What the patient wants and what the son, daughter or wife wants. Is there any concordance in that? That we wanted to know. And we found that only 50% of the time what the patient wants is what the caregiver wants. So that means, the caregiver would want an aggressive ICU care and all the state of the art treatment, but the patient would want a peaceful end of life at home. So that is where we need to look into patient preference also, especially in our country, when the whole village will be inside your consulting room, whereas the patient will be sitting outside and told that don't tell that he has cancer. So that's where I think we should be more aware and try to give more time to these patients before we take a decision on treatment. This was also interesting that nobody wanted a very premium cancer center to treat when we had older patients with cancer. They just needed somebody who knows them better. For example, a geriatrician or a palliative care physician, rather than a premium oncology center to treat. And who should treat you? If you ask a younger population or aware population, I'm sure majority would want the best medical oncologist or the best surgical oncologist to treat him. But here they wanted a team of doctors who can treat them. So that's what our patients want, and they don't want to spend too much of time for treating these patients. The cost also will be an issue, as I am sure it would have been discussed in the morning. So if you look at the geriatric assessment in the newly diagnosed cancer patients, you have a lot of tools which will actually objectively tell us whether a particular patient is fit to undergo certain form of treatment. So this was one of our publication where we did how to set up a geriatric oncology clinical services, especially in a country like India, where we have varied resources, where we have set up of 5-star facility hospitals to very charity and set up where the even a basic oncology facility may not be there. So how to set up? You should ideally have an outpatient, inpatient, and a community outreach programs. Outpatient patients should ideally be somewhere between all the floors should be, all the facilities ideally should be somewhere in the vicinity. You can't ask elderly patients to keep going from one building to other. And especially if you are doing a comprehensive geriatric assessment, it should be in one floor or at least in one building. So we also had some, guidelines on how to do the vaccination and screening, because community outreach is also equally important when we talk about quality of care in geriatric oncology patients. So everybody keeps asking, what is the ideal care? Who should be there? Which team should take care? Whether palliative care should be the fulcrum, whether geriatrician should be there, or finally oncologist should hold on till the end of life for all the patients with the cancer. Well, the International Society of Geriatric Oncology tells that there is no ideal model. What suits for you, what suits for your culture, what suits for your hospital, what are the facilities that you have that's based in which you should look at your models of care. And if you have a model of care which is ideal to your situation, I am sure the quality of care that we can give to our patients will improve. So you just can't be a consultative geriatric model, because as you know, the geriatricians are very far and few for us to get in each of our hospitals. So it will be okay that you just take a consult, do a CGA with him, and then get on with your oncology practice. So that's called a consultative geriatric model. An integrated geriatric model where you already have a setup, then a geriatrician just comes and visits and goes, and of course oncologist with referral to other specialties. So there are different models of care where finally you can give good quality of life for your advanced older adult patients. And of course the communication is very, very important in geriatric oncology practice, especially what you are gaining out of surgery. So, if you are doing a surgery, how long it will take to recover, what will be the time for you to go back home, what will be the time when you can, you may require a caregiver support, how much nursing care you will be required, do you need an assisted living or a transition care. So all this has to be communicated. Compared to a younger patient, you can be that the recovery is very fast and it can be quick. So your communication should ideally reach the best case, worst case scenario. For example, if the surgery goes successfully, 2 days later you will be at home. But if it is not so successful, then 20 days, 30 days you may have to spend with the assisted from the healthcare workers. So I think the communication is also very, very important when we look at geriatric oncology quality care. So somebody who is above 60 years, what are we going to do? You should have a OPD waiting area. You should have an oncology OPD. Then you should have a geriatric oncology coordinator, a geriatric OPD, then you will have the axillary intervention, and then you go to the oncology OP, and then finally you have a multidisciplinary tumor board. So I told you this is the ideal way to go, but whatever is possible in your center is what we should aim at. So if you look at one of the model is where you have a continuum of care. That means you start off with oncology facility, you take your geriatrician's help, your palliative care is also with you. So home care, the assisted living, the end of life care, all can be done under one system. That's called one of the comprehensive geriatric cancer care model. And that helps us when you have a multidisciplinary team where you have a qualified geriatrician, you have trained staff who are taking care of elderly patient. All your subspecialty is looking at in improving the care in elderly. Then that will be one care model where you can improve the quality of care in elderly patients. The slide is not moving. No, it's not moving. Okay, so the ideal scenario, as I told, it's a practical way is to look at you have a solution where you actually look at the model that suits you, which will improve the quality of life and in the care of your patients. So it can be either a palliative care physician who is taking care of the entire thing. If your end of life care is what we are looking at. If you're looking at a curable setup, then your oncologists take the primary role, and then the geriatricians and the palliative care physicians work out together to it. But whatever is the care model, I think the elder care patients deserve good quality of care. And what requires the support is how the patient journey will help in a comprehensive as a treatment for their decision making. Many of you would have seen that unlike West, the whole family would want you to not to reveal the diagnosis of cancer at the first setting. So that you should be respecting, and you should continuously have a multiple family decision making meetings rather than tell everything in the first meeting or deny the patient any information. So I think that we should be sensitive culturally, and of course end of life and caregiver support is the most important. We should be aware that when you have a long drawn out process, there can be a caregiver burnout, so that also has to be taken care by our psycho-oncology and palliative care model. So if you look at one of the models that we actually looked at and published in the International Geriatric Oncology Society of meeting, we had a comprehensive geriatric assessment done for 150 patients of ours, and see whether that has helped in improving the quality of care or intervention, and we could prove that there is improvement in care. And of course, what should be your goal? You should be realistic. You develop model of care that suits your your institution, and then try to build what is best for you. Ideally, we should have an oncologist, geriatrician, and research people working together, and that would be the key aspect of developing a care model which will help our older patients with cancer. Thank you, and thank you for the opportunity.